and welcome to this second of two webinars on the officially titled The Workup and Management of the Pruritic Dog, with a focus very much on atopic dermatitis. And this second, we talked in the first webinar about the workup of pruritus and the diagnosis of atopic dermatitis. And in this session, I'm going to be covering the management or the treatment of atopic dermatitis. And I've called this talk, "What should I use and when should I use it?" Because it's one of the most common questions that we get, you know. And I think the next slide will kind of demonstrate why that is the case. So this is a little bit of a history lesson in managing atopic dermatitis. And back in the early 80s, when I graduated, we didn't have very many options for managing pruritus. In fact, most of the time we were just treating itch. We weren't effectively diagnosing atopic dermatitis. So we were managing symptoms, and we were doing that with combinations of antihistamines and steroids, mostly, both long-acting steroid injections and glucocorticoid steroid tablets and creams. And then in the when I developed an interest in dermatology, I started using allergen immunotherapy. And in fact, actually, this treatment, allergen immunotherapy, has been around for several decades now. Since probably the 1940s would be the first time it was used to manage atopic dermatitis in a dog with pollen allergies. So it's been around for quite a long time. And then in the 90s, we started to get the introduction of things like essential fatty acids. And in the early 2000s, Cyclosporine was licensed. And this was a real breakthrough because it gave us another effective treatment as an alternative to steroids. And then there were other steroid formulations, such as topical glucocorticoids, the hydrocortisone acetonate spray. More fatty acids came along, and then the atopic license eventually expired, which left room for generic cyclosporine therapies. And then kind of probably 10, 15 years ago, maybe a little bit longer, we started to become interested in the effect of skin barrier function and the role that plays in atopic dermatitis. And so products were developed that moisturize the skin and improve skin barrier function. So these are spot-on treatments, but there are other topicals. And then other treatments started to be used. The human product, which is tacrolimus Protopic, which is kind of, it's a cyclosporin-like medication used topically. And then in 2014, another major kind of breakthrough was the development of oclocitinib, or Apoquel, which has been enormously popular, a useful drug in the management of this disease. And then we started to use sublingual allergen immunotherapy. So as opposed to injections, we're now starting to use a formulation where it's delivered orally, or at least under the tongue. And then most recently, again, we had the development of lokivetmab, or Cytopoint, which we'll talk about later on. So there's a huge plethora of treatments out there now. And it's little wonder that a lot of people find this area very confusing. And, you know, it is one of the reasons why we get asked this question, well, which is the best treatment? Which is the one that we should be using? You know, what do you recommend? Well, so which is the best treatment? So infuriatingly, I'm afraid, my answer, or you speak to any dermatologist and they ask them which is the best treatment, the answer always begins with, well, it depends. And it depends on a lot of different things. And I want to go through what those things are and hopefully give you a framework or feel for how these different treatments fit into different clinical presentations and circumstances. The first step really with managing any case of pruritus is to know what it is you're treating. So we covered the workup of and the investigation of atopic dermatitis in the first webinar, so it might be worth referring back to that, but it really helps to know what you're treating. You know, the treatment for scabies is highly specific and fleas is highly specific, and if you've got a Pyoderma or a Malassezia infection, then those things need to be treated. They don't necessarily respond well to drugs. Although they cause pruritus, they don't necessarily respond well to the drugs that control pruritus associated with allergic skin disease. So make a definitive diagnosis, and I've put in here, recognize when it's been made. I touched on this in the last webinar, but you know, quite often we'll see a case where it's quite clear actually that the diagnosis has been made, but it's not really been recognized. And if that happens when these cases drag out over many weeks or months, sometimes years, and see different people in a multi-vet practice, and it is difficult to maintain case continuity and know exactly, right, we've got to the point now, we know what we're dealing with this dog, the diagnosis has been made, let's move on and put in place some kind of long-term treatment program rather than just firefighting the whole time. Having made a diagnosis, and we're talking here, made a definitive diagnosis of atopic dermatitis, and that this is assuming this dog does not have food-induced disease, so the dog will require long-term therapy. And it's really important that the client understands that atopic dermatitis is an incurable disease. There is no magic bullet that's going to switch the dog's symptoms off for life. But in the vast majority of cases nowadays, it is a manageable condition. And it's important to, I think people fixate on the idea of allergy. It's just an allergic disease, but it's much more than that. We've already talked a bit about the skin barrier function issues surrounding atopic dermatitis. And yes, certainly allergy is an important driver of the pruritus. But these dogs are often very prone to secondary yeast and bacterial infections that it's important to recognize and manage. And a lot of them get ear disease and so on. So there are other things that need to be dealt with in addition just to managing the allergic symptoms. And I think it's really important to try and involve the owner in the decision about how you're going to manage this disease. You know, they definitely need to be enrolled in this. This is a treatment they're going to be involved in for the rest of the dog's life. That doesn't mean to say that you can't and shouldn't adapt or change treatments, and I'll show some examples at the end of this presentation where we had to do just that. But yeah, they really need to be enrolled in the decision and engaged in the treatment. It's not something that they can just leave to you as a vet. And emphasize that, you know, it's a condition that requires lifelong, ongoing treatment. And, you know, just because the dog gets better or seems better, that's not a reason to stop treatment. It happens all the time, and inevitably the symptoms recur again. But if we can encourage them to maintain treatment levels, then the long-term outcomes will be much better. So the other thing to think about is, what is it we are actually treating? These three dogs all have the same disease. They all have atopic dermatitis, but quite clearly they have very, very differing presentations. And their treatment options are going to be, oh, I'm sorry, I might have to just forgive me for a second while I close all this down. So otherwise going to get constantly bombarded. Okay, apologies for that. Okay, so yeah, these three dogs all have atopic dermatitis, but they have clearly very, very different presentations and require very different treatment and management, and this is part of the "it depends" I talked about at the start. This dog really has very mild clinical signs, but the main presenting sign is pruritus. It's just some mild erythema. This dog has very severe, long-standing, poorly managed atopic dermatitis of 5 years duration, and you'll see the outcome with this dog later on. So what we're dealing with here is very severe chronic inflammation of the skin, and of course pruritus. And in fact, as you'll see later on, there's a significant secondary yeast and bacterial component going on here. And this dog has inflammation, and you can sort of tell even from this distance, really, these multifocal pigmented macules that the dog has over the ventral chest here are highly suggestive of a bacterial infection. So there's inflammation, there's infection, and there's pruritus. So all three of them are pruritic, but they're pruritic for different reasons. And there isn't a one-size-fits-all treatment, and you have to identify what's going on in each of these three individuals and use your treatment appropriately. So other considerations with treatment, it does depend which treatment you might select out of those many drugs that we have available to us and many options we have available to us now. Depends which one you use, depends a bit on duration of therapy. So are we talking here about short-term therapy? So we might want to manage pruritus during a diagnostic workup, for example, during a diet trial, where you want a drug that's going to work very rapidly and be effective. So there's no point in using a treatment like cyclosporine, which takes several weeks or sometimes months to really kick in and have an effect. You want something that's going to work almost instantaneously in that situation to control pruritus. You may just be giving the drug for a few days at a time. So drugs like ocrelizumab, Apoquel, or steroids would be the most appropriate treatments to use in that circumstance. And when you stop them, the symptoms will recur again quickly. So you can tell whether the other things that you're doing, for example, the diet trial, are making any difference. Seasonal flares, for example, you may want a treatment to cover for a period of time during the summertime. I really like lokibetamab cytopoint in that circumstance. It can be a very useful drug used just to control flares. The dog may be on other treatment for most of the time, but it has a flare during the spring or summer, and you can give an injection of lokibetamab, and that will tide the dog through that allergy season. And then there are it may be that we're talking about long-term, ongoing treatment, non-seasonal disease, where treatment's going to have to be maintained all year round. And, in that circumstance, we might want to, for example, try and avoid the use of glucocorticoids, where you're more likely to get significant adverse effects. I'm not saying we don't use them in that circumstance, but they perhaps certainly wouldn't be first choice, whereas they would be quite useful in a seasonal flare or for short-term therapy. And clearly, there are many patient factors that come into consideration. An older, infirm dog would definitely require different treatment from a young, fit, healthy dog. And then there are many owner considerations. There are lots of owners who are, well, gosh, owners have all sorts of different considerations or ideas about what they find acceptable or unacceptable. Some are dead against the use of steroids. Others just don't like the idea of using any drug that could act on the dog's immune system, which is difficult because they pretty much all do act on the immune system. So this is something that needs to be discussed with the owner. And as I said earlier on, we really need to enroll them in this therapy and engage them, and they need to be confident in what their pet is being treated with. When we're managing atopic dermatitis, it's important to have an holistic approach. So there are these different aspects of treatment of this disease, and we shouldn't just be focusing on looking for a drug to deal with the itch. So there are these 4 aspects. So flare factors are very important, and flare factors are reasons for a sudden recurrence or increase in pruritus in a dog that may otherwise be stable on some kind of therapy, or maybe not on therapy, but they have periodic flares. And the most common reason for these periodic flares of pruritus is infection. So typically a malassezia or a staphylococcal infection. There may be increased in allergen load. Spring, early summer is a common period for that. There may be aspects of food allergy and exposure to food allergens, and external parasites can also be responsible for flares. So I'm not going to say any more about those in this talk, actually, but if you have a dog that's doing well and suddenly has a recurrence of symptoms, look very carefully for evidence of infection before assuming that it's just a flare of the allergic symptoms. Skin and coat care is the second aspect to managing atopic dermatitis. I'm going to say a little bit about that. Allergen-specific immunotherapy, I'm going to say more about, and for us this is a very valuable treatment for managing atopic dermatitis and would be our treatment of choice in the majority of cases where it's appropriate. And then, of course, there's pharmacotherapy, and that's what we opened with, really. And you know, we now have all these different options for pharmacotherapy, and I'm sure there'll be more on the way, but we'll have a look at various drugs and how they fit into the management of this disease. So skin and coat care, a little bit about that. Shampoos can be useful, and they have all sorts of beneficial effects, whereby washing the dog, you're removing allergen from the skin surface, so pollens or dust mites or whatever. And this is a percutaneous absorption of allergen, this disease. So you can, if it's not an inhaled condition, the allergens penetrate through the skin. So if you can wash them off the skin surface, that has to be helpful. It's useful for managing microbial infections, in fact, the essential part of managing microbial infections. So they're antiseptic, and some shampoos have some anti-pruritic effect. They have moisturizing effects, all useful attributes for atopic disease. And I don't have time to talk about all the individual shampoos. That would be the subject for another webinar, really. Spot-on treatments. So there are these ceramide and fatty acids replacers, if you like, which the aim is to improve skin barrier function. And certainly if you had a dog with dry, scaly skin, it would definitely be worth considering treating with one of these products. And certain breeds are definitely predisposed to dry skin, and the Labrador Retriever, atopic Labradors, often do present with a dry, mild dandruff, mild scale over the dorsal trunk. That would be a situation where one of these products might be useful. So if we're looking at our 3 friends here and deciding where these treatments would fit in, well, actually they might all benefit in one way or another from a shampoo. This dog could have an anti-pruritic shampoo. This one here, the Westie, could have would benefit from an antiseptic shampoo, as we'll see later on, and this one too. But don't expect these treatments to have a dramatic effect in controlling pruritus. They're really, we need to think of these as more as adjuncts to therapy. There may be dogs that do respond, but mildly effective cases, but in most cases you're not going to see a sudden dramatic reduction in the level of pruritus. Okay, I want to say something about allergen-specific immunotherapy. This is, as I'm sure you know, this is the administration of increasing doses of allergens to ameliorate symptoms associated with subsequent exposure to the allergens. What you're doing is you're giving them as much allergen as they can tolerate, really, and the idea is that it alters their immune response to the allergens, so that on subsequent exposure to those allergens, natural exposure to those allergens, they don't react in the same way. And and this indicates that traditionally we've always given allergen immunotherapy by injection, and artibectrin would be the most commonly used allergen immunotherapy formulation in the UK, and this is what Avacta will supply. And sublingual immunotherapy, though, we're also starting to use a bit, and it seems to suit some owners. So why should we consider allergen-specific immunotherapy? Well, it can be very effective, and over the years we've treated thousands of dogs in our practice with allergen immunotherapy, and there are some dogs that just do fantastically well with this treatment, and roughly a third will be completely controlled with allergen immunotherapy and not require any other therapy. A third will be improved, but probably still require additional treatment from time to time. But it can really have it can reduce the amount of other treatment that's required, and can be cost effective just for that alone. And then, unfortunately, roughly a third of dogs have absolutely no response to this at all. So, although you need to give it for a year before making an assessment of efficacy, a third of your cases will show no benefit. This is the only treatment that really addresses a cause of the disease. So everything else is just treating symptoms. But here we are addressing the allergic component and actually switching off the allergic component of this condition. So that's an important point. There are no long-term adverse effects associated with allergen immunotherapy. It's completely safe, and can be very cost-effective. And owners like it. They like the idea that you're not having to give a drug for life. However, this is not a treatment for itch or inflammation. And, many dogs with severe symptoms will require additional treatment, certainly during the induction phase of immunotherapy. So this Labrador on the left here with these very mild symptoms, you might get away with just using allergen immunotherapy on this dog alone. But these two dogs, start them on allergen immunotherapy, but you're going to have to manage both of these dogs, inflammation and pruritus, in addition to starting them on immunotherapy. And then the hope is that eventually immunotherapy as a sole treatment will be sufficient to control their signs once all the infection and inflammation has been controlled. And you need to allow a year or up to a year treatment. We say 10 months, probably 10 months or up to a year treatment before making any final assessment of the efficacy of this treatment. Okay, so that's allergen immunotherapy. And I would say for us in our practice, this would be the treatment of choice for dogs where we've made a diagnosis of atopic dermatitis and they have positive results on intradermal testing or serology that correlate with the dog's history. Definitely our treatment of choice. For long-term management, I should say. What about essential fatty acids and antihistamines? So they have in the past, maybe less so now, but been widely used to try and control pruritus and signs of atopic dermatitis. EFAs have some anti-inflammatory. These little diagrams here are kind of, if you like, a simplified outline of some of the pathways and inflammatory and cellular interactions in atopic dermatitis in the skin. And the more red arrows, basically, the more effect the treatment is having. So EFAs work on skin barrier function, and they have some mild anti-inflammatory effects. And it has been shown, they're obviously very safe. They have no serious adverse effects. Excuse me. And they have been shown to have a steroid-sparing effect. So these are levels of steroids required to control pruritus in atopic dogs, and the lower line represents the steroid dose required in dogs that were also given essential fatty acid supplements in addition to steroids. So this is the best study that shows that EFAs have some effect. Antihistamines, on the other hand, there's very limited evidence for their efficacy, and they're not very widely used now. We have much better options. I think if you are going to use an antihistamine, it makes sense to use them very early on because they only do one thing, and that is block H1 receptors. And there's a whole load of downstream effects from and a whole lot of other activities that are going on that really antihistamines have no effect on at all. So, but if you block histamine receptors very early on in disease, it makes sense that they might stop some of these downstream effects. Having said that, there was one study not so long ago that did show that some owners did find them effective, but that's not a controlled study. We occasionally use them. Sometimes they can be appropriate. And if we're looking at these dogs here, well, if I'm going to try antihistamines on any of them, it's going to be this guy. I really wouldn't expect them to have any effect on these two dogs here. Glucocorticoids, on the other hand, are very effective. And there are some important things to say about them. First of all, they're obviously anti-pruritic, but they are potent anti-inflammatories, and the number of red arrows that are shown here indicates that they have a very broad spectrum anti-inflammatory and immunosuppressive effect on many different cell types. So they are very good for controlling not just itch, but also skin inflammation. And we try and use short-acting products wherever possible, and if we can, topical therapy for localized lesions. They're inexpensive. They can be used short-term in many different circumstances, so we'll use them along with allergen immunotherapy during the induction phase of allergen immunotherapy. We'll use them short-term during diet trials. They're extremely useful for the management of otitis externa, given systemically. And occasionally we'll use them for seasonal or short-term atopic signs. And we also use them in the long-term management of atopic dermatitis. And there may be that's the most appropriate therapy for any individual dog. One thing I would say is they may exacerbate infection, and they may not be effective if you have a pyoderma or a yeast infection. So if you're using glucocorticoids, you're not getting a good response in terms of management of pruritus, then look for infection. So which dogs might I use them on here? Well, certainly they would be effective. Maybe a bit of a sledgehammer for this dog here with its very mild signs, but it may be the most appropriate treatment if cost was a factor, for example. This dog here, yes, with this severe level of very severe inflammation, one of the first things you want to do in try to get this dog's skin back to something more approaching normal is to deal with the infection. And actually, prednisolone or glucocorticoids might be indicated here, provided you've identified and controlled infection. I probably wouldn't use them here because this dog has quite a severe pyoderma, so I would be looking at focusing on treating the pyoderma first and not using steroids. And then, of course, they have all these, they have a big potential for adverse effects, and all these dogs are all showing severe signs of glucocorticoid excess. This dog has dermatitis and is also clearly quite Cushingoid looking. This dog has severe iatrogenic Cushing's, as does this one with pot-bellied appearance, and this one here has severe calcinosis cutis, which is this dog was actually not atopic, it was being treated for a neurological condition. So when we're using steroids, we want to use the lowest dosage that just controls the symptoms, and if ideally given on alternate days. That's not always possible, but that's what we aim for. And I like to educate owners on how to achieve that dosage, because the dosage changes. There may be times when the dog needs a bit more, and then we get away with a bit less, and then needs a bit more again. And it's much better if the owner understands how they can adjust the dosage at home, and you'll have much better long-term control rather than every time the dog flares, it gets into a mess, and they bring the dog back into you into you for first aid treatment, so you're kind of lurching from crisis to crisis. We want to try and maintain control of the dog's disease. And in terms of monitoring dogs on steroids, well, weight checks, physical exams, and urine analysis to look for subclinical urinary tract infections, which are a complication. Cyclosporine, another anti-inflammatory and potent anti-inflammatory and immunosuppressive drug that acts mainly on T cells, but has a lot of other effects, as you can see. So it has good antipruritic, but also good anti-inflammatory effects, similar to steroids, really. And it's been shown to be safe and effective in atopic dermatitis. There are some drug interactions with cyclosporine that you need to be aware of, particularly that with drugs that inhibit the cytochrome P450 pathway, such as ketoconazole, which can result in much higher plasma levels of cyclosporine. The thing to remember about cyclosporine is that it takes a long time to kick in and have an effect. There's really no point in giving it for a week, or even I would say for a fortnight. You want to give this drug for 4, 6, 8 weeks before you start to make any assessment of efficacy. And because of this slow onset of the drug in a very pruritic dog, you're going to have to manage pruritus during that period. And it's been shown that prednisolone or oclicitinib, which is Apoquel, can be used in addition to cyclosporine during that kind of induction phase of treatment. And there, its main indication, well, it has many indications actually in all kinds of dermatology conditions, but its main indication is in Atopic is the long-term management of the disease. We also have used it, we tend not to so much now, in dogs that are on long-term steroids, and we're trying to get them off steroids to do intradermal testing because it does not affect the results of allergy testing. And we'll use it also during the induction phase of immunotherapy while we're waiting for the allergen immunotherapy to kick in and have an effect. But it's not appropriate for the management of acute flares because it is too slow acting. So where would I use it with our three friends here? Well, yes, it could be used to treat this dog with relatively mild symptoms. Again, it's a bit like a steroid, it's a bit of a sledgehammer to crack a nut, perhaps, but would be a reasonable option. And certainly, it would certainly be indicated in this dog because of its anti-inflammatory effects once we've controlled this dog's infections. But again, I wouldn't use it here. I'd be focusing here on treating this one's Pyoderma before I thought about any immunosuppressive therapy. And then we have oclicitinib, one of the newer kids on the block. I'm sure you've kind of all used this, and this may be your favorite go-to treatment for atopic disease. And certainly, it's a very effective antipruritic. It works by blocking the receptor for interleukin-31, which is a cytokine that's responsible for an important cytokine for inducing pruritus. It's not the only cytokine involved in pruritus, but in some dogs, it is a major player. So by blocking the effect of interleukin-31, we can control pruritus in those cases. But it has a very limited anti-inflammatory effect. It doesn't have anything like the anti-inflammatory effect that glucocorticoids, cyclosporine have. It's very quick acting and has a very short half-life, which is both one of its advantages and one of its disadvantages. It's effective in many cases, but not all. And I think people get so used to it working, they get a bit of a shock when a case comes along where it just does nothing. And that may be because interleukin-31 is not important in that particular dog's pruritus. And we have there are different indications for it. It's very useful during diagnostic workup. So we'll use it to get dogs off steroids, for example. We use that now rather than cyclosporine just because it's so much quicker acting. It's great, can be great for controlling acute flares of pruritus. And also we use it in some cases in the long-term management of atopic disease. And it has very few short-term adverse effects. Occasionally you might see the odd dog with some GI signs. There are adverse effects. I mean, but they do tend to be relatively mild. I would advise don't use it in demodicosis. We've seen a few dogs now that have developed demodicosis on this drug. I wouldn't use it. I definitely would not use it in Pyoderma. I wouldn't. It's quite an immunosuppressive drug, or seems to be. So we would not use it in dogs that have cancer, for example. So you have to be a little bit selective about those cases you use it on. And when we're monitoring dogs on long-term therapy, we tend now to do full CBC and serum biochemistry every 6 months or so. And occasionally we do see dogs with elevated liver enzymes where we've had to stop treatment, but they're in the minority, I would say. And where would I use it here? Well, I would certainly use it. It would be a good option for treating this dog's pruritus. But the middle one, the Westie here, has very severe inflammation. And this drug just doesn't have the anti-inflammatory effect that we would need to control the severe skin inflammation. And I definitely wouldn't use it here where this dog has a Pyoderma. But for managing just pruritus per se, with no other complications, a good option. The dosage, I want to say something about the dosage for oclocitinib. That is the standard dosage, 4.4 to 0.6 mg/kg every 12 hours for 2 weeks, and then you have to go to daily therapy. And the reason that that's the case is that it can affect the erythropoietin, receptor for erythropoietin, and bone marrow function. So that's why it's not recommended to give it twice daily for longer than 2 weeks. And what we find is it's often effective when given twice daily, but then you get this bounce back of recurrence of pruritus when it's reduced to once daily therapy. The dog is often still a lot better, but the owner just notices the dog has gone from being completely itch-free to suddenly being itchy again, and this panics them. The trouble is, long-term twice-daily therapy is contraindicated. There are people that use it, but in our practice, we do not. We have concerns about that. So we tend actually not to give it twice daily in most circumstances, especially if we're using it long-term. We just start with a once-daily therapy and see how the dog gets on. And you don't then have this bounce back after the dose reduction after 2 weeks. We don't see a good response when secondary infection is present. So it's not good at controlling the itch associated with infection. This was one of the dogs that developed demodicosis on oclocitinib treatment. That's what these lesions are here and here. It's difficult because it's so short acting. It's a difficult drug to taper. And our preference would be to try reducing the daily dosage rather than switching to alternate day therapy. We seem to get better results that way. And then, kind of last of all, there's lokivetmab, which is one of these. It's an antibody against interleukin-31. So unlike oclocitinib, it works extracellularly. It works in tissue fluids to bind and neutralize IL-31 before it can bind to the receptor. And it is a very targeted therapy. It's mainly antipruritic, although it does have some effects against inflammation by blocking downstream effects, I think. It's very rapidly acting. Again, like oclocitinib, it's very effective in many cases, but just don't expect it to work in every dog. There will always be cases where it just doesn't help. It's a safe treatment, we certainly use it if it's appropriate for long-term management of atopic dermatitis, but we have noticed in a few cases some reduction in efficacy over time, and that may be because the dog starts to develop its own antibodies against this antibody, it is a canonized mouse antibody, but there's still a little bit of mouse in there. So that may be what's happening in those cases. For that reason, dogs that do really well, I actually prefer to keep it do really well with lokibetamab, I prefer to keep it for managing their flares rather than just using it all the time. It's a great drug if you have dogs that are immunosuppressed or sick in other ways. It's very safe to give to them. Obviously, if owners find it difficult to pill their dogs, it's useful in that situation. And again, we can also use it if we want to get dogs off steroids prior to intradermal testing. So where would I use it here? Well, certainly this dog here would respond well to, you'd expect this dog to respond well to lokibetamab. It's probably not going to control the itch associated with infection in this dog, and it's not going to be effective enough in controlling the inflammation, at least when the dog is at this stage, in this case. So that's me covered the drugs. I just want to spend a little bit of time, last minutes really, just going through some cases and case examples, which I hope you'll find helpful. So this is Bailey, who was a 4-year-old German Shepherd cross, and presented with non-seasonal facial, pedal, ventral pruritus, otitis externa, and conjunctivitis. So if you want, this dog is reading the textbook and screaming, I'm an atopic dog. There was no response to these workup histories, by the way, are a little bit abbreviated. So this dog would have had thorough rule-out vector parasitic disease, but didn't respond to a diet trial. And when we saw the dog, he was being well enough controlled with steroids and an antihistamine and a topical hydrocortisone acetonate spray. And although he was well controlled, the owners were really worried about him having to be on steroids long term. When we examined him, he had malassezia on his paws to start with. So the first thing we did was treat that. We wanted to get him off the steroids in order to do intradermal testing. So we used oclocitinib. And in fact, we actually used it in short bursts during the period we were trying to get the dog off steroids, the 3-week steroid withdrawal period. And because we were using it in very short bursts, we did say to him, I give it twice daily for 3 days and repeat if the dog becomes very itchy, and then you can repeat that as required. And then 3 weeks later, we were able to do an intradermal test, or could have done serology testing, and the dog was positive for house dust and storage mites. So at that point, we have a diagnosis of atopic dermatitis associated with dust mite allergies. And for us, allergen immunotherapy would be the treatment of choice, long-term treatment of choice. So we started him on allergen immunotherapy and continued his Apoquel to control pruritus during the induction phase of the immunotherapy, and we continued to treat his malassezia infections on his paws. And after a 1.5 years of allergen immunotherapy, it's clear he was improving during that period, but finally after a 1.5 years, it was possible to stop oclocitinib. And this dog, this was probably 7 or 8 years ago now, and I still see this dog once a year for his annual checkup, and he's still doing well just on immunotherapy alone. So he is one of the 30% that do extremely well with this treatment. Here's another one. This is Gus, a 4-year-old male neutered Labrador, and you can see he's a very itchy boy. He's a paw chewer and a leg chewer, and he gets a bit better when you give him Apoquel and spray him with steroids and give him prednisolone, but his pruritus is never really satisfactorily controlled. When we examined him, he had an otitis, but he also had, you can see from this photograph here, there's this erythema and partial alopecia, and there was scaling over all the distal limbs. And when you do cytology, you find masses of malassezia from this dog. So, and this is probably why the oclocitinib is not working, and the steroids are not working fantastically well to control this dog's pruritus. So we treated the yeast infection to start with, and when I saw him a few weeks later, he'd improved with the antifungal treatment, but was still nibbling his paws. We got rid of the yeast infection, but he's still pruritic. So that remaining pruritus is likely to be due to the underlying atopic dermatitis. So we started him on a diet trial, and we gave steroids, this time once a day for 3 days, repeated as, not steroids, oclocitinib to control pruritus, used intermittently during the diet trial. And after 6 weeks of the elimination diet, he was a lot better. But the foot chewing recurs rapidly following withdrawal of the Apoquel. So it's actually the Apoquel that's resulting in the improvement, not the diet. So we did an intradermal test, and he actually had masses of positive reactions to dust mites and pollens and mold spores. And the owner wanted to start him on sublingual immunotherapy because it suited her lifestyle better, really. So we started him on that, and oclocitinib was continued, and we continued to manage the yeast infections. And then, although I saw him in the interim period, after 15 months, I had an email from the owner saying that she'd stopped the oclocitinib 3 months previously, and that Gus's pores had been great. And he lived for several years after that on his allergen immunotherapy, although he did have occasional flares of pruritic and needed to be treated with oclocitinib during those periods. She's a very diligent owner and kept the antifungal treatments going. So, you know, he probably falls into the middle category, so good response to immunotherapy, but still required additional treatment from time to time. And that's a photograph of his pores that the owner sent me sometime later, which shows you can see the improvement. So here's this dog that we were looking at before. This is his name was Robbie, and you've seen him quite a bit. So I just thought you might be interested to see what the outcome was with this guy. So he's a 6-year-old neutered male Westie. I saw this dog a long time ago. This is probably even pre-Atopica, actually, but he had a 5-year history of pruritus. He'd been managed mainly with steroids and clearly not doing brilliantly well. And you know, he had a massive, long differential diagnosis list. You know, dermatitis and Pyoderma and malassezia infections, even cutaneous lymphoma might be a differential here. So we started by doing coat brushings and skin scrapings and found nothing on that. We did cytology, and he had a bacterial overgrowth. You can see these cocci here on the stuck to the skin cells. And he had a yeast infection. This is not malassezia pachydermatis. This is a different type of malassezia, but you treat it the same way. So the first stage is to thoroughly rule out ectoparasitic disease and treat the microbial infections. And nowadays we would use isoxazoline for that and topical therapy. And this dog has severe skin inflammation. So once the infection has resolved, we need to start him on a drug to manage this severe inflammation. And prednisolone would have been a reasonable option, but the owner had not much faith in that. He also is severely alopecia, and one of the side effects of cyclosporine is that it induces hair regrowth. So that's a useful attribute in this dog, and that's the drug that we decided to go with to start with. And you can see after 3 months, just a great improvement. And this, and then after 9 months, one of the problems with cyclosporine is that dogs with this treatment can become hirsute, and they need their hair clipped from time to time. So good response. And at this stage, he's still on daily therapy, but we want to try and reduce the dosage if we can. And we see a lot of dogs that responded well to daily cyclosporine therapy, but then the data sheet recommendation was followed and the dog was switched to alternate day therapy, and they relapsed. Now, how I would recommend you taper cyclosporine is by doing this. If you get a good response, so treat them daily until maximal response. That might be 3, or it could be more time than that. Then start to taper the drug very slowly. So start by stopping it on just 1 day a week. Wait a month. And if the dog is still okay, then reduce to 5 days per week treatment, and then wait a further month before you reduce the dose, and so on. So reduce the dosage by 1 day per week every 4 weeks until drug completely withdrawn, or until clinical signs start to recur, or pruritus or skin inflammation starts to recur, and then you find the lowest dose. So there are some side effects we need to be aware of with cyclosporine. I mean, vomiting or GI signs are the most common, but we also see dogs with gingival hyperplasia. That's not that uncommon a symptom, and occasionally dogs with it's rare, but they can get quite severe and quite rapid onset papillomatosis. And then we've also talked about the hirsutism effect of cyclosporine. That's a dog that developed multiple histiocytomas after being on cyclosporine. You can expect that with any drug that suppresses the immune system. Okay, this is probably the last case, but this is Jack. He's a different kind of case, actually, because this dog is not reading the textbooks. This dog is a 14-year-old Westie who had had pedal pruritus from 12 years of age, you know, and had been treated with octreotide but hadn't responded. And that is not suggestive of atopic disease. Atopic dermatitis is a disease that starts in young dogs. So with these cases, and we do see them periodically, we need to make absolutely sure there's no internal disease. You know, we've seen older dogs with liver cancer or other liver disease. We've seen them with other systemic illness that resulted in this late onset pruritus. So they need a thorough investigation. But despite this, we could find nothing with this dog and made a tentative diagnosis. Well, this dog looks like the diagnosis of exclusion is atopic disease, although it's not doesn't sit comfortably with this history diagnosis. There was no response to cyclosporine, and the only drug that we could use that controlled this dog's signs was prednisolone. And actually, he did extremely well with prednisolone, a relatively low dose, but did start to develop severe side effects after 2 years. Developed a steroid hepatopathy. He actually had an ocular disease that was thought to be associated with steroid treatment, had to have an eye removed. And at that point, Cytopoint became available. And he was treated with Cytopoint, and it worked extremely well for this dog. And this is the kind of case, this kind of old dog had, at this stage, other comorbidities, and Cytopoint is a very nice choice in cases like that. Oh no, there is one more case. That's right, a particularly problematic one. This is Rory, another Westie. I probably should have had French Bulldogs in here because they're the most common breed that we see now, and they can be very problematic to manage. But this dog had a diagnosis after thorough workup of atopic dermatitis and secondary bacterial and yeast infections. He was started on sublingual immunotherapy, and to control his pruritus, he was also given cyclosporine and an initial short course of methylprednisolone to control the pruritus during the induction phase of the cyclosporine. And we treated his yeast and bacterial infections. This dog history goes on a little bit, but he was okay over the winter time, but fled in the spring. The owner continued with his sublingual immunotherapy, but didn't think the cyclosporine was doing anything, so it was withdrawn. Octreotide became available, and typically, with a lot of the cases we see, did okay on every twice daily therapy, but was unacceptably itchy on once daily treatment. We added in topical hydrocortisone acetonate for his feet and some of the other focal areas that he was particularly pruritic over. Continued topical antimicrobials. After 10 months of sublingual immunotherapy, which is the late summer the following year, he was still very pruritic, not doing particularly well on octreotide, so we switched him back to cyclosporine plus methylprednisolone, and that low dose of methylprednisolone and the cyclosporine, the combination of the two was effective in controlling pruritus, and the owner elected to stop the sublingual immunotherapy because she didn't feel it was doing anything. So over the next 3 years, his symptoms were pretty well controlled on this combination therapy of cyclosporine and methylprednisolone. But always reducing the methylprednisolone dosage always resulted in recurrence of pruritus. The lowest dose we could get him down to was 0.3 mg/kg every 24 hours of the methylpred, and he stayed on the standard dose of cyclosporine. Then, inevitably, after long-term steroid use, he started to get some problems. He developed a cruciate ligament rupture and signs of steroid excess. And at that stage, Cytopoint became available. And so in desperation, we tried that. And actually, he was a dog that did well on Cytopoint alone.
So what about this combination use? So some cases of atopic dermatitis are extremely challenging to manage. Occasionally we do need to use combination therapy, and the combinations that we've used have been glucocorticoids and cyclosporine, oclocitinib and cyclosporine, and lokivetmab and oclocitinib, so cytopoint and apoquel. What you should be aware of, though, is if you're going to use these combination therapies, is that the use of different immunosuppressive drugs, glucocorticoids along with cyclosporine, you start to suppress different arms of the immune system, and the risks of disease associated, there's a higher risk of disease associated with immunosuppression in those cases. So, sorry, I think I've gone on long enough, and just to wrap up, I would say that managing atopic dermatitis can be an art as well as a science. So sometimes we do need to get a little bit creative with some of the more problematic cases. Remember to identify and treat those flare factors, in particular, identify infection. I stressed this in the last webinar, but please do rule out food allergy wherever you can in any non-seasonally atopic dogs before starting them on long-term therapy. And, certainly, as I've said a couple of times already, I would say allergen-specific immunotherapy is indicated in all cases of non-seasonal atopic dermatitis where you have positive serology or positive intradermal testing and the dog does not have a food allergy. And we're lucky now. We live in an age where we have a number of different effective and relatively safe pharmacotherapies or biological therapies, but don't expect them, no matter how great you think some of them are, don't expect them to work in every case. None of them are universally effective. None are universally safe, and we need to consider both short-term and long-term adverse effects when using these treatments. So, kind of the choice of treatment depends on the manifestation of the disease and other factors, owner factors such as cost, their expectations, and adverse effects to the treatment. Okay, and if you want more on guidelines on atopic dermatitis, I would recommend these papers, which are free to download and very helpful.